Thank you all for coming. It's my pleasure to introduce Marissa Hendrickson, our speaker today, talking about Ondansetron. Marissa Hendrickson was born in southeast Minneapolis and lived there until she left to attend Wellesley College in Boston, where she majored in chemistry and Japanese studies. I'm not sure either of those happen in the ED anymore. She's remained in Boston for the next 4 years, first working as a management consultant for Renaissance Solutions, a private company, and then in healthcare policy research at the Harvard School of Public Health. She then moved to Cleveland to attend medical school at Case Western Reserve University. She also completed a residency in pediatrics in Cleveland, as well as her fellowship in pediatric emergency medicine at Rainbow Babies and Children's Hospital. She bravely joined our division in 2008 when she was our first faculty member besides me and Mark, and we were working in the back storage room of the emergency department on the other side of the river. She has led our efforts since then to develop and refine our clinical care guidelines, our EPIC ED order sets, and has research interests in clinical standardization, informatics, public advocacy. She's actually won a AAP, a grant for public advocacy in the past, and for healthcare policy. Today she's going to speak on Ondansetron in the emergency department, which has had a truly dramatic impact on our day-to-day clinical practice. Thank you.
Good afternoon, everyone. Thank you, Ron, for the kind introduction. As Ron said, the topic we'll be discussing today is the role of Ondansetron in pediatrics. I do have a couple of disclosures. First, many of the uses of Ondansetron, known commonly by its trade name Zofran, that I'll be discussing remain off-label in children. One of our studies was supported in part by an ABIM Foundation grant. I have no other financial disclosures. Our objectives for today's session will be to summarize the history of Ondansetron use in pediatrics, which, as Ron said, has really exploded over the past 20 years. We'll also be discussing the research supporting its use in ED management of acute gastroenteritis in particular, and clearing up some misconceptions about it being a mistake to use it for acute vomiting. And last, I'll be describing some recent research in this area that we've been working on in our ED. Starting in the dark ages of research on this topic, the first mention of Ondansetron in PubMed was in 1987. Then known by a number, its effects on guinea pig gastric emptying were compared with those of metoclopramide and haloperidol. It's not clear to me why they opted to study haloperidol in this regard, but it was ineffective. However, Ondansetron was found to be 200 times more potent than metoclopramide, also known as Reglan. Metoclopramide was then widely used as an antiemetic in oncology and other applications. The first PubMed mention in humans was that same year. 15 adult chemotherapy patients were given a series of IV and PO doses of Ondansetron. Although all 15 were selected because their nausea and vomiting had historically been refractory, only one of them reported nausea and vomiting with this regimen, and there were minimal side effects. The authors noted that although metoclopramide was widely used, its use was limited by dystonic reactions and other side effects due to its dopamine receptor antagonism. They hypothesized that the antiemetic effect of Ondansetron was due to antagonism at 5-HT3 serotonin receptors, a novel mechanism that might be expected to have fewer side effects. A few previous studies had assessed two other 5-HT3 antagonists, tropicitron and bimesitron, but these had not passed into clinical use. An editorial in the same issue of The Lancet said that 5-HT3 antagonism might be particularly useful in children because they are more prone to dystonic reactions with metoclopramide. This turned out to foreshadow significant interest in the use of Ondansetron in pediatrics. Over the next few years, Ondansetron was a hot topic in the literature, to the point that a dedicated research symposium devoted to it was convened in London in 1989. In 1991, it was approved by the FDA and hailed as an important new antiemetic, particularly in the world of oncology. However, unfortunately for the world of pediatrics, only a few of the pre-marketing studies had included children. In the US, there were 2 abstracts with a total of 27 children. A few small studies in Europe had included children as well. Even so, initial FDA labeling was for prevention of emesis associated with chemotherapy in patients 4 years old and older. The majority of the early literature continued to focus on its use in chemotherapy and radiation, but interest spread rapidly to other fields. In particular, there was a lot of interest in the anesthesia literature regarding using it for postoperative nausea and vomiting. In fact, this is still the only other use for which it is officially labeled by the FDA. And as always, with promising new medications, there was significant interest in using it for additional indications. The first case report in the pediatric emergency medicine literature was in 1992. They described a 17-year-old patient with vomiting that made it impossible for her to tolerate the N-acetylcysteine that she needed after a large acetaminophen overdose. At that time, NAC was only given orally, so it was imperative that she be able to take it. After receiving a single dose of IV ondansetron, she kept down the NAC. The authors made the point that ondansetron was preferable to older antiemetics in toxicology patients because it has no sedative effects, so it would not add to the risk of airway compromise or other complications. Along with the early enthusiasm for ondansetron, however, there were some concerns raised in case reports. The first report that I located that raised concern for ondansetron prolonging the QTC interval appeared in 1992. This has continued to be the most discussed and probably most concerning complication over the past few years, given the risk for life-threatening arrhythmia. That same year, there was also a case report of severe thrombotic complications in a chemotherapy patient with pre-existing thrombocytopenia. However, the authors noted that it was unclear how much to implicate the ondansetron, given the patient's severe illness and polypharmacy associated with his cancer diagnosis. And later, a 1999 case report raised concern that ondansetron had caused risk to a patient by masking her post-tonsillectomy bleeding by preventing her from vomiting up the blood, leading to a delay in her care team becoming aware of the ongoing bleeding. However, the child did eventually vomit up the blood, and they were able to return her to the OR for hemorrhage control. In the early days of its usage, while it was still under patent, ondansetron was relatively expensive compared to older antiemetics. As a result, some authors argued that it should be offered only according to cost-saving guidelines. However, others pointed out that given the acuity of some of the dystonic reactions that were common with older antiemetics, the decreased need for nursing interventions and rescue medications in those cases could be considered to offset some of the costs. Although the initial FDA approval only extended to children over 4 years of age, post-marketing surveillance reported significant off-label use in younger children, including the IV form given orally. Currently, the labeling has been extended to include babies and young children 6 months of age and older. Those are my children when they were 1 and 2, and unfortunately did not need any ondansetron. In 1995, the use of the IV form given orally was officially reported in a case series of children undergoing ambulatory chemotherapy. In this group, the oral ondansetron administration resulted in 74% of ambulatory chemo days being emesis-free. They also reported a reduction of hospitalization in these patients with no major toxicities. In 1996, there was early experimentation with syrup formulations, which were found to be safe and well tolerated. 59% of children in their study preferred the strawberry to the grape, but about 15% expressed no preference. I have not tasted ondansetron liquid recently, so I don't know if the strawberry ultimately prevailed. Does anyone know what it tastes like? I've tried the ODTs, they're pretty tasty. But anyway, in the same time period, people were reporting success with other uses. For example, ondansetron was shown to be beneficial in cases of severe itch associated with chronic cholestasis and with intrathecal morphine administration. It was also found to be a benefit in the often challenging case of patients with cyclic vomiting. Acute gastroenteritis is a subject near and dear to my heart because it's such a common presenting complaint in the pediatric ED, and I'll be spending most of the remaining time of this talk discussing the literature addressing it. The first mention of the use of ondansetron in acute gastroenteritis was a rat study in 1994. They showed a decrease in visceromotor response to rectal distension in rats with experimentally induced colitis. No comment on how the rats felt about this. The next mention of the use of ondansetron in acute gastritis, which you'll see me abbreviate as AGE, was in 1997. A study in Venezuela randomized children to receive a single IV dose of ondansetron, metoclopramide, or placebo. They used a higher dose of ondansetron than the 0.15 milligram per kilogram that we commonly see now. Medication was given during a 4-hour rehydration period at the beginning of a 24-hour hospitalization. The study was supported by Glaxo Wellcome, manufacturer of Zofran brand ondansetron, the only type available at the time, I believe, who could certainly have been seen to have had a vested interest in broadening the indications for ondansetron. In this study, the proportion of patients who had no vomiting or retching at all during the study period was increased, with 58% in the ondansetron group versus 17% of the placebo group being completely emesis-free. There was no significant difference found between metoclopramide and placebo. However, this was the first of several studies to note an increase in the number of episodes of diarrhea. Significant increases were found in both antiemetic groups. It has been theorized over the years that this effect is due to the retention of fluids and toxins that otherwise would have been eliminated through vomiting, although the authors note that they could not rule out baseline differences in their two groups. I'm not aware of research addressing the question of how willing parents would be to trade more diarrhea for less vomiting, but I think a lot of us consider it plausible that people would consider that a worthy trade. The next randomized controlled trial to assess the use of ondansetron in acute gastroenteritis was completed at Texas Children's Hospital in 2002 with 145 patients. They were given oral ondansetron, a first dose in the ED, followed by 5 more doses to be given Q8 hours after discharge from the ED. This is one of only 2 studies that I found that specifically addresses multiple dose use. After receiving their medication, patients were started on oral rehydration therapy, sometimes abbreviated as ORT, in the ED. Patients who were tolerating oral fluids were then discharged with instructions for ongoing rehydration, with a recommendation that they continue the scheduled small doses of oral fluids that they had been using in the ED, plus the initiation of an extremely bland diet after 24 hours. This study found significant increase in the proportion of patients who had no vomiting and decrease in the number of episodes of vomiting while the patients were in the ED. However, the mean number of episodes of emesis was quite low, and the median was 0 in both groups. They also found significant decreases in the proportion of patients requiring admission to the hospital and the delivery of intravenous fluids because of failed oral rehydration. You'll see these used as outcomes a lot through this literature because everyone prefers to avoid IVs, both from the children's perspective, but also from a resource utilization perspective. And likewise, admissions are expensive and time-consuming for families. But again, diarrhea was increased in the ondansetron group relative to placebo. In addition, they found an increased rate of return to the ED in the ondansetron group, with 2 patients returning for persistent vomiting and 2 returning for diarrhea. No patients returned in the placebo group in this study. Despite their use of a 6-dose regimen after discharge from the hospital, they found no change in ongoing vomiting at 24 and 48-hour follow-up. However, in this case as well, both the mean and median number of episodes of emesis were quite low. A somewhat grinchy letter to the editor in response to that study said, "An additional concern includes shifting parental efforts away from oral rehydration therapy toward medication-seeking behaviors. However, since many of us entered medicine with the goal of relieving suffering, it's hard to feel too strongly about decreasing ED utilization by ensuring that vomiting children avoid taking an effective medication." So in any case, the struggle against vomiting marched on. There was another randomized controlled trial in 2002 out of Boston with 107 patients who all had a working diagnosis of acute gastroenteritis. In this case, all patients had an IV placed. They were then given IV ondansetron or saline placebo. Each patient was also given a normal saline bolus, followed by a period of IV fluid at twice maintenance rate. This study was also supported by Glaxo Wellcome, although the authors reported that the company's only input was reviewing the finished paper. In this trial as well, the proportion of patients with complete cessation of vomiting increased significantly. However, in this case, they did not identify a corresponding increase in diarrhea. They showed no overall decrease in admissions. However, an analysis of their randomized group allocations had shown that their ondansetron group had a higher proportion of patients with very low baseline bicarbonate values, 14 or below, considered a sign of more severe dehydration. When they removed these patients with the lowest bicarbonate values, as well as patients who were on their second visit for the same illness, which were also allocated unevenly between groups, they did find a significant decrease in the rate of admissions in this smaller subgroup. 2002 was also the first mention in the literature of the orally dissolving tablet formation, known as ODT. At that time, it was marketed under the trade name Zofran Zydis. This formulation has become the preferred one for our use in the ED, and I think for a lot of other applications as well. In 2006, there was a randomized controlled trial published in the New England Journal of Medicine. For many of us, this was the paper that encouraged us to seriously consider using ondansetron in patients with acute gastroenteritis. It was conducted at Children's Memorial Hospital in Chicago and included 250 patients with recent vomiting, diarrhea, and mild or moderate dehydration. They were randomized to receive single-dose ODT ondansetron versus placebo, then given at least 1 hour of intense oral rehydration in the ED. If they were unable to keep down the first tablet, they were given a second one 15 minutes later. The need to do this reflects the not always widely understood fact that although the ODT formula dissolves in the mouth, it is not orally absorbed. It still must be swallowed and kept down to be effective. The manufacturer, having evolved at this time into GlaxoSmithKline, provided the tablets. I've been able to see the evolution in their name by reading all this literature. Although the labeled dose for chemotherapy is 0.15 milligrams per kilogram, these authors used a simplified weight-based dosing. These simplified doses can be easily given using the available 4 milligram ODT tabs and have become the standard in our ED and elsewhere. We do, however, often use the adult standard starting dose of 4 milligrams rather than the 8 milligrams listed here for larger children and adolescents. As in previous studies, this group reported a significant decrease in the proportion of patients who had any emesis during the rehydration period and a decrease in the number of episodes, although, as in other studies, the mean was quite low. The number needed to treat to avoid vomiting was 5. They also found a decrease in the use of intravenous fluids with a number needed to treat of 6, and a small but statistically significant decrease in ED length of stay of 14 minutes. However, they too reported a short-term increase in diarrhea. In this case, they were measuring the episodes of diarrhea while still in the ED, which you would expect to be low. They contacted discharged patients on days 3 and 7, assessing the need for return to care, delayed IV rehydration, and hospitalization. No significant differences were found in any of these outcomes. And unfortunately, although ongoing prolonged diarrhea has been one of the concerns in the earlier studies, they did not assess ongoing diarrhea in their follow-up calls. In 2006, ondansetron first became available as a generic. Although I wasn't able to find historical pricing data, my memory from having been in practice in that time is that the retail prices were around $80 per pill before it went generic. Now, 10 years later, the cash retail price for 4 milligram ODT tablets is still relatively expensive, but more manageable, $4.50 per pill, and it is generally covered by insurance. Also in 2006, there was a randomized controlled trial conducted in Syracuse, New York. They recruited 166 ED patients with acute gastroenteritis for a comparison of single-dose IV ondansetron to IV dexamethasone. The medication was given along with a normal saline bolus, followed by reassessment of tolerance of oral rehydration therapy at 2 and 4 hours. Patients were admitted to the hospital if they were still unable to tolerate PO intake at 4 hours. In this study, admission rate was significantly decreased from 20% in the placebo group to 4% in the ondansetron group. There was no significant difference in the dexamethasone group versus placebo. However, the mean number of episodes of vomiting and the rate of repeat visits at 24 and 72 hours were equal. In 2008, there was another clinical trial conducted in South Bend, Indiana, focused on patients who failed a controlled oral challenge, so potentially somewhat sicker than the other children that had been enrolled in other studies. They enrolled 106 such patients and randomized them to receive single-dose ODT ondansetron or a matched placebo. In these patients, they found that ondansetron led to significant decreases in the proportion requiring IV fluids from 55% to 22%, and in the rate of hospital admission from 13 to 6%. Then, in 2009, there was a trial conducted in a Turkish observation unit, recruiting 109 patients who, again, were not tolerating oral rehydration. They were randomized to receive 3 Q8-hour doses of ondansetron or placebo. The first 2 doses were given at the beginning and the end of an 8-hour stay in an observation unit. A third dose was sent home with them to be given at home at the 16-hour time period. This was only the second study I found that specifically addressed multi-use dose in acute gastroenteritis. In this group, vomiting was significantly decreased on both 8 and 24-hour reassessments, with a number needed to treat of 2. In addition, almost all the ondansetron patients were able to be discharged at 8 hours, a significant improvement compared to the 78% discharge rate in the placebo group. In this investigation, too, diarrhea was increased, although in this case the magnitude of the difference was small. Moving on from the smaller randomized controlled trials, in 2010 there was a large database study conducted in Atlanta. A particular focus of their investigation was on the question of whether giving ondansetron in the ED for vomiting from presumed gastroenteritis risked masking a more serious diagnosis, such as appendicitis, intussusception, or an intracranial mass. This concern for missing or delaying an important diagnosis had been a big issue for antiemetic skeptics over the years, so it was an important question to address using a large database. They used a primarily electronic data collection method, given the 34,000 patients they were reviewing. However, they manually reviewed the subset of patients who were admitted on a second visit to the ED to ensure a complete understanding of the final diagnosis. Overall, they found widespread use of ondansetron in this large group of gastroenteritis patients. And they showed that although patients who had received it had more ED revisits, overall they had fewer total hospital admissions than the group that did not receive ondansetron. And importantly, when they evaluated the subset of patients who were admitted to the hospital on a second visit after having been discharged, there was no evidence of severe diagnoses being masked by ondansetron. The rate of alternative diagnoses was not significantly different between the two groups. This was true when they considered all serious diagnoses together, and also when they looked at individual diagnoses, including appendicitis, intussusception, bacteremia, pyelonephritis, small bowel obstruction, and intracranial tumor. This was very reassuring to all of us, as the idea of delaying the diagnosis of an intussusception or a brain tumor is a frightening outcome in our practice. In addition, they reported that 34% of patients were discharged with a prescription for ondansetron, with likewise no concern for increased diagnosis masking in the patients that received home prescriptions. This is the first report I found that addressed this practice in any way. Although I think we all find it plausible that it would be beneficial to send patients home with additional doses of a medication that has been helpful in the ED, this practice has not been well studied. The two studies that have directly provided multiple doses have not really shown ongoing benefit, but PRN usage has not been studied at all. As usage has increased, there have been additional reports of adverse events. A few of these include a report of ventricular tachycardia in a surgery patient who was not previously known to have any cardiac rhythm issues. After the acute incident passed, he was subsequently diagnosed with congenital QT prolongation. A second one was a child with known risk for malignant hyperthermia who died after a single dose of ODT ondansetron. He was discharged from the ED and returned 3 hours later after his visit with a temperature of 41 degrees and asystole, and was not able to be revived. Additionally, there was a boy with hypoglycemic seizures that were thought to be potentially related to a single dose of IV ondansetron, and also a patient who took 15 of his own 4 milligram tablets that he had because of his lymphoma therapy in an intentional self-harm episode. He developed transient hypotension requiring pressors for 12 hours. But even so, ondansetron had the potential to have a very large positive impact if properly used. A 2010 economic analysis estimated that administration of it to eligible children in US EDs with vomiting and dehydration due to acute gastroenteritis would prevent over 29,000 IV insertions and 7,000 hospitalizations per year. In addition to the obvious benefits of avoiding painful needle sticks and time-consuming hospitalizations for patients and families, it was calculated that this would save over $60 million per year to society and healthcare payers. As the evidence mounted, usage of ondansetron for acute gastroenteritis took off during this same time period. A 2011 survey of pediatric emergency medicine providers in the US and Canada showed that 2/3 of US and almost half of Canadian providers reported regular use of antiemetics, primarily ondansetron. The authors concluded that ondansetron administration had become routine. However, at the same time, a multi-site study in Canada showed significant variation among institutions and also variation by provider training, with pediatric emergency medicine trained providers using ondansetron more frequently than their general pediatrics or general emergency medicine trained colleagues. Then, also in Canada, there's a lot of interest in this in Canada. In 2012, a large retrospective study was considered 3,500 ED visits in Toronto between 2003 and 2008. This investigation found an overall reduction in IV fluid use and an increase in ondansetron use during this time period. Time series analysis showed a level break in the use of IV fluids after the introduction of ondansetron. They also found that during this period, ED length of stay for these patients declined from 8.6 to 5.9 hours, both of which sound very, very long to me. In addition, Ron's nodding his head, revisits and the need for intravenous rehydration on a subsequent visit decreased significantly. Also in 2012, another large database study in Atlanta evaluated 32,000 patients who had received ondansetron in the pediatric ED. Of these, 12,620 were identified to have had diagnoses other than acute gastroenteritis. As you can see from these top 10 lists, the diagnoses that they used it for included a variety of other infections, injuries, and illnesses. Not surprisingly, the list of diagnoses for patients who were admitted to the hospital tended to be more serious than the list for those who were able to be discharged. In this group, they found that patients with diagnoses other than acute gastroenteritis were admitted to the hospital significantly more often than acute gastroenteritis patients. This is not surprising given the presence of more serious diagnoses such as appendicitis and shunt malfunctions on the list. They also reported that 37% of those who were discharged from the ED were given prescriptions for additional doses, adding to the very small literature on the practice of prescribing ondansetron at ED discharge. Another large study in 2012, authored by Anupam Karbanda, who's now across town at Children's, evaluated ED records from 160,000 visits from acute gastroenteritis at 21 hospitals to assess utilization patterns. They showed wide variation in rates of use of both ondansetron and IV fluids in the 21 hospitals studied. Overall, they had found that 52% of children seen in EDs with acute gastroenteritis were given ondansetron. This caused the authors to wonder if we had actually tipped over into overuse, since the earlier economic analysis had estimated that about 16% of patients seen in the ED with acute gastroenteritis were appropriate candidates for ondansetron. They also, somewhat surprisingly, found no correlation at the hospital level between high levels of ondansetron use and low levels of IV fluid administration. Even so, enthusiasm for use in gastroenteritis continued to spread. In Ireland, there was a hospital that had a pre-existing waiting room oral rehydration protocol. They added ondansetron to it and did a pre- and post-intervention analysis, finding a significant decrease in the need for IV fluids in the ondansetron patients, but no change in the overall admission rate. Broadening consideration back to the system level, a 2014 database analysis of 804,000 patient visits for acute gastroenteritis considered the effect of changing usage on large-scale patterns of care. This assessment found that during their study period, ondansetron use increased significantly from about 0 to 42%. However, despite this increase, they found no overall change in the rate of IV fluids or hospitalization when they compared high use and low use periods. They did, however, find a small decrease in 3-day revisit rates, which contradicted some of the earlier studies that had shown an increase. One reason they offered for the relatively unexpected finding of unchanged IV fluid and hospitalization rates was that only 14% of the patients who were given IV fluids also received oral ondansetron. Although their study didn't allow for consideration of timing, this could indicate a missed opportunity to try using oral ondansetron and oral rehydration in patients who seem to be failing to tolerate oral rehydration prior to placing an IV. They also found very wide variation by institution. Based on the mounting data over the years, Cochrane reviews and other meta-analyses have shown gradually increasing enthusiasm. A recent systematic review in 2015 found 31 trials with over 4,000 patients. Their analysis confirmed that use of ondansetron significantly decreases the need for intravenous fluids. And also, although they noted that 3 studies described an increase in diarrhea, for methodologic reasons, these could not be meta-analyzed. They also noted that no study had shown benefits associated with ondansetron use following emergency department discharge, although the number of studies addressing this is small. And with regard to safety, in 2014, a comprehensive safety analysis assessed all reports of arrhythmias, both from the standard literature and the gray literature, including conference reports and abstracts that didn't make it into journals. Most importantly, for our use in the ED, they found no cases reported of arrhythmia after a single dose, or a single dose given orally. Of the 60 unique reports of arrhythmia in the literature, 11 were in children. Most of the reported cases involved IV dosing, and most had associated significant medical history, concomitant use of a known QT prolonging medication, or both. The authors ultimately advised against routine screening before single oral doses, but did suggest targeted screening for patients with known risk factors or when doses will be given intravenously. I was talking this over with the author, Stephen Friedman, at PAS last week, who, alert readers will notice, has written about half of the studies I've been talking about. And he said that after his review of the literature for this paper, his view was that no one should ever use Ondansetron IV. His thought was that if they vomit up the first dose, it's safer to give a second oral dose than to progress to IV dosing. Oops. I'm sorry about that. But given the frequency that it's been used over many, many years, IV and with repeated dosing in hematology oncology, I think that's a bit of a stretch. But I thought it was an interesting perspective that IV dosing is more dangerous than PO. And pregnancy. I almost didn't put this in because it's a quagmire and it's been a lot in the news and it's been all over, but I finally decided that before I move on to discussing local research in this area, I should at least mention it. Over the past 15 years, it has become widely used in pregnancy and has been found to have fewer side effects, less sedation, and superior efficacy compared to alternatives. Same as in the hem-onc patients, same as in our patients. It's an effective drug. However, more recently, there have been a few reports raising concern for teratogenic effects, particularly given that the most active period for nausea and vomiting in pregnancy is the first trimester, when the fetuses are most sensitive to teratogens. The particular effects that have been most reported are cardiac defects and cleft palates. My overall impression, based on a very brief review of this topic, is that there's disagreement in the literature, but many experts continue to consider it safe. And on a personal level, I have to say I'm very glad these concerns hadn't come to light in 2008. Now I'd like to shift away from the overall history and describe a couple of studies we've conducted here at Masonic. And even though I know most of you work here too, I couldn't resist putting in a picture of our beautiful building. So in 2011, shortly after moving into the new hospital, we introduced a triage-based protocol to encourage oral rehydration for acute gastroenteritis. It included a standardized assessment of dehydration by the triage nurse, with early provision of ondansetron and oral rehydration to appropriate patients. To avoid offering oral fluids to potential surgical patients, we required a report of diarrhea, not just vomiting. And for our implementation study, we focused on younger patients because they're the ones most likely to present with dehydration from gastroenteritis. We compared prospectively gathered post-intervention data with retrospective controls. Our protocol excluded the most severely ill patients, defined as level 1 or 2 in the 5-level standard ESI triage system. This is a very small proportion of our gastroenteritis patients. We also excluded patients who had vomiting without diarrhea, severe abdominal pain to the point that it might raise concern for appendicitis, and chronic medical conditions that might complicate oral rehydration therapy, including many of these subspecialty patients that we know and love here at Masonic. Patients who were included had a dehydration score calculated according to a standard scale adapted from a previously published scoring system. The scale calculated a score from 0 to 8 by adding up scores on 4 clinical assessments. These were general appearance, eyes, mucous membranes, and tears. And this adapted version was put together by Jen Zaremba, who is sitting in the audience and is no longer one of our nurses, but was at the time. The score guided initial therapy by the triage nurse. A score of 5 or above, considered moderate to severe dehydration, led to a recommendation for MD notification for early assessment and possible IV fluids. This amounted to only 1% of the patients in our study. Patients found to have a score of 0, indicating no dehydration at all, were offered an unstructured PO challenge of clear liquid or a popsicle if they had not been vomiting. If the nurse assessed them to have active or recent vomiting, they were given ondansetron, followed by a short waiting period before being offered any fluids. These interventions were initiated at the time of triage, generally prior to physician assessment. The middle group, with scores of 1 to 4, considered to represent some dehydration, was again offered ondansetron if they had vomiting. In this case, however, we followed the ondansetron with an attempt at formal oral rehydration with scheduled administration of 5 milliliter measured amounts in a syringe from World Health Organization oral rehydration solution. Patients who did not have recent vomiting were offered oral rehydration immediately following triage. The implementation of this protocol led to an increase in the proportion of patients who were given ondansetron and a decrease in the time elapsed between arrival and provision of the dose. It also increased the frequency of oral rehydration being documented, although this may have been partially due to the additional documentation associated with the prospective data collection for the study. Importantly, for the needle-phobic children of the world, the implementation of the protocol also led to a decrease in the use of blood testing and in the proportion of patients who were given IV fluids. However, it did not significantly change the rate of admission or unscheduled return to care. We were hoping for a decrease, but at least we didn't get an increase from doing it this way. Our rate of unscheduled return to care here is higher than many that are reported, but that's because we assessed unscheduled return to any site of care, including doctor's offices, other EDs, urgent cares, rather than only to our ED, which is sometimes what's reported. Other findings from this study included the fact that children and families did not at all like the timed rehydration with WHO oral rehydration solution. They did not think it tasted good, and they did not want to drink 5 milliliters every 5 minutes. Really, especially for those who got ondansetron, after they felt better, they just wanted something to drink. We found that giving Pedialyte and Gatorade worked better, and I apologize for using the trade names, but I couldn't do it. In addition, we noted that 52% of patients were discharged with prescriptions for ondansetron, although the protocol was silent on this issue. The protocol really ended right after triage. And last, we found good correlation between the nurse and physician assessments of dehydration. Ondansetron administration at triage remains a standard in our ED, primarily for acute gastroenteritis, but also for other circumstances with vomiting. Another study that we've been working on here at Masonic concerns the practice of providing prescriptions for home use at discharge. As I mentioned before, this practice has not been well studied, although a few reports have mentioned that it is done. For our assessment, we electronically reviewed medical records from 2012 through 2014, evaluating patients in 2 separate but overlapping groups. The first group was all patients with a discharge diagnosis of acute gastroenteritis. The second included all patients who were given discharge prescriptions for ondansetron, regardless of diagnosis. We wanted to look at that larger group partially to identify what other indications we were using it for, but also because with the way that coding goes, sometimes patients might have gastroenteritis but not get coded as acute gastroenteritis. They might get coded as vomiting and diarrhea, or there is a lot of overlap and imperfection in the coding system. Of the 996 patients who had a discharge diagnosis of gastroenteritis, we found that use of ondansetron was frequent, both in the ED and at discharge. 65% of the patients received oral ondansetron in the ED, and 71% were sent home with a prescription. This indicates that at least a few patients were sent home with a prescription without first receiving an oral dose in the ED. And I don't have these numbers, but I believe we also had some patients who were sent home with prescriptions without ever receiving any dose, oral or IV in the ED. Which might make sense if they had reported vomiting at home but weren't vomiting now, but the parents were afraid it would happen again. In this group, neither ED use nor home prescription of ondansetron had any effect on 7-day return rates. Again, a decrease would have been nice, but at least we didn't find an increase. For that group that was prescribed ondansetron for any indication, we identified 2,287 patients. In this group, we found that a majority of the prescriptions were for various abdominal or GI diagnoses, including acute gastroenteritis, but it was also prescribed for other infections, illnesses, and injuries. This group had a rate of ED return that was similar to that of the gastroenteritis group. When we assessed the dosing that we prescribed, we found that the dose that was advised on the prescriptions was close to the traditional 0.15 milligrams per kilogram. The fact that there is a range at all is likely explained by our frequent use of the 2 and 4 milligram standard dosing, as well as the use of 4 milligrams as a maximum dose for larger children. Once in a while, we send people home with the 8 milligram tablets, but usually we max out at 4. However, As you can see, the number of doses we sent patients home varied wildly, from 1 at the conservative end to 112 at the less conservative end. This was a bit surprising to us because anecdotally, when we all talk about it, I think most of us intend to send patients home with a few doses in order to encourage patients to return for assessment if they have prolonged symptoms. Because we do have that study saying that masking of alternative diagnoses is uncommon, but I don't think any of us want to think that one of our patients with gastroenteritis is at home using Zofran for 3 weeks without asking somebody if that's something else is going on. However, I think the wide range of doses is partially due to the fact that most of our prescriptions are written by rotating residents, and in a busy ED, we don't necessarily discuss the number of doses to prescribe in every case. In addition, I have noticed in doing this work that Epic has some ordering defaults of 10 tabs for the ODT 4 milligram tabs and 20 days supply of the liquid for TID for 20 days. These defaults probably come from the adult or oncology worlds, but they're less well suited to our practice, and we're discovering that as we assess this. So areas for further research and improvement that we've identified from this would be standardization of those ordering defaults to provide just a few doses. And in the long run, it would be helpful to have a more systematic consideration of the role of as-needed dosing for patients discharged from the ED, since none of the previous investigations have assessed whether as-needed ondansetron dosing after discharge improves patient-significant outcomes like overall patient comfort, emesis has been studied in some of the studies, but not very much, and also whether it decreases missed school or work days. Ideally, a randomized controlled trial of PRN usage would address this, but it might have to be quite a large trial to find an effect because the frequency of ongoing vomiting is low in gastroenteritis. In conclusion, ondansetron has a 25-year history of safety and efficacy for children with nausea and vomiting. Arrhythmia is potentially the most concerning complication, but has not been reported with single oral doses. And multiple studies have shown decreases in intravenous fluids and hospital admission for with ED use in acute gastroenteritis. However, outcomes after ED discharge, such as ongoing vomiting or return to care, have been less responsive to ondansetron as an intervention, either in the ED or for homegoing. In particular, multi-dose use has not been shown to improve outcomes. However, PRN home use has not been studied, but it is widely prescribed, both here and in the few other institutions that have published their experience. So I have a few acknowledgments. I'd like to thank the staff and resident physicians and the nurses of the UMMCH ED for their participation in the projects described, especially Mark and Ron for the opportunities they've given me, starting with hiring me when it looked like it might be just the three of us. And also Jen Zaremba, who I mentioned is here, was a co-author on the Triage protocol study. In addition, I'd like to thank resident Dr. James Gray for his work on the home prescription project, and also Dr. Anupam Karbanda, who was instrumental in the Triage protocol before he moved down across the street to Children's. I very much appreciate the department and grant-funded statistical support provided through the CTSI and the grant funding provided by the ABIM Foundation. And last, I'd like to thank my family for putting up with me for having my nose buried in PubMed these past few weeks. I have included this extremely tiny set of references for the online slide set, although good for you if you can read them. Now I'd be happy to take any questions. John.
Thanks, Marissa. That was a great review.
Thanks.
I appreciate it. The evidence you presented would seem to support fairly indiscriminate use of ondansetron, and I wonder, much in the way we use Tylenol for fever while we sort other things out, it seems like this could be used in a similar way for vomiting. When's it going to be available over the counter?
I didn't run across anything about that when I was reviewing the literature, but I remember hearing a few years ago that was a possibility, and I think it hit a hitch with the QTC prolongation issue. That has scared a few people, and a couple of reports of major ventricular arrhythmias or death, and that'll tip that off the table quickly. But I've wondered that myself, and because it is so widely used, and really the numbers of the safety is that it's excellent. Yeah, nice.
Sort of related to that, you mentioned a letter to the editor or something along the way where there was concern that wide use might lead to medication-seeking behavior. Do you see that in practice? Are people coming
Yes, we
in
do.
and asking for it?
Yeah. Well, and I think it's interesting. I mean, culturally for me, having grown up in the 70s and 80s, and I remember when you had gastroenteritis, you would just vomit until you stopped vomiting, and then that was that. And you would drink small sips, and that was how it is. But on the other hand, it's kind of like Tylenol for fever. I mean, nothing awful happens if you don't treat a fever, mostly. But people feel better when you treat their fevers, and so why wouldn't you do it if you can? And I think that's kind of been the tension here. I mean, yes, technically, acute gastroenteritis is almost always a self-limited illness, and so why must we treat it this way? But on the other hand, it's terrible when your kid has vomiting, and so why wouldn't we treat it? And I think there has been some consideration. I mean, I do wonder anecdotally how it affects ED utilization, because you see people, we have turned vomiting into a solvable problem. And so I think people maybe do come in earlier because they've heard about it, or they know they want it, or they've had it before. Sometimes people, and I think sometimes with those studies that showed increased in bounce back rates, it might be because they ran out and they want more. And so, and on the one hand, that doesn't seem like a good use of ED resources, but on the other hand, maybe they just should have had more. So it is a balance. I think sometimes people, especially with the single dose studies, they sometimes had, I think some of the people came back because it worked so well the other time and they want more. And so it is a little, it's sort of a balancing act, but it relieves suffering to do this. And I think, as I mentioned earlier, I think a lot of us have kind of made the mental calculation that even if diarrhea does go up, you'd rather stop the vomiting than the diarrhea. I actually was just thinking, I want to do like a 2-question survey of our ED patients and say, would you rather have vomiting or diarrhea for your kid? To prove it, but. Any questions? Well, thank you everyone for your attention.
You have been